My name is Axel Grothey. I'm a medical oncologist at Mayo Clinic in Phoenix, Arizona. I'm here to discuss, as part of a roundtable discussion, optimization of late-line therapies in metastatic colorectal cancer. With me are Dr. Bekaii-Saab from the Mayo Clinic in Phoenix, Arizona, and Dr. Eric van Cutsem, providing a European perspective from Belgium Leuven. Yeah.
Thank you.
Great to have you here. So we'll talk about late-line therapies or the later-line therapies in metastatic colorectal cancer. And a lot has changed in the last 5 to 10 years. Eric, so what's your perspective on what are key drugs, key treatment approaches that people need to be aware of?
Well, indeed, a lot has changed, as you said, Axel. And we have seen for the late lines of therapies 2 new agents that have been approved, regorafenib and trifluridine. Both agents have been approved.
So there's TAS-102.
TAS-102, yes. In Europe, we always say trifluridine. But these 2 agents...
sounds long, you know?
Yeah, but that's the way it is. That's a generic name. These 2 agents have been approved. They have some benefit for patients. We don't have head-to-head studies for these 2 agents, but they contribute to the longer survival. And as you and others have studied in the past and have published, every time we can add a new agent to our therapeutic strategy, to the algorithm, it seems that we improve the survival, not spectacularly, but with a couple of months extra, and that's important for the patients.
I mean, you know, the point I always like to make is we haven't really seen this one breakthrough event in colorectal cancer, except perhaps something we'll talk about later, the immunotherapies in MSI-high and mismatch repair deficient cancers. But patients benefit from the steps that we have seen over time. The more agents we have, the more we are able to influence the disease course, the longer patients will live. Tony, you know, so regorafenib and TAS-102, so what are some of the key aspects of these agents in terms of what are the data based on, and what do you think are the challenges here?
So the 2 agents that have the space in the refractory setting are TAS-102 and regorafenib, and they're different drugs. TAS-102 is a cytotoxic agent. It's a part of the superfamily of fluoropyrimidines. It's not 5-FU. It has differences with 5-FU and capecitabine. It tends to, in preclinical models at least, to have activity where 5-FU fails because of its properties. Regorafenib is a multi-kinase inhibitor, targets VEGF, but also targets other elements in the tumor. So they're different in their composition. They don't have overlapping activity per se, and their toxicity profile, and we'll talk a little bit more about this, are somewhat different.
Yeah. So Eric, you were involved in the development of both agents on the phase 3 level. So we have the CORRECT study, CONCUR, we have RECOURSE, and we have the TERRA study. Can you give us some of the results of a high-level overview and the difference between CORRECT and CONCUR in the different studies for TAS-102?
Well, if we just make a global summary, both agents led to, the use of both agents led to an improved survival. That was true for as well the regorafenib versus placebo studies as the studies of TAS-102 versus placebo. The amount of benefit was very similar, but we don't have cross-trial comparisons, so we don't have data comparing TAS-102 with regorafenib. It's always regorafenib versus placebo or TAS-102 versus placebo. And the design of the 2 pivotal registration studies with TAS-102 and with regorafenib were quite similar. Chemorefractory patients, refractory to all available agents, being fluoropyrimidines, oxaliplatin, irinotecan, bevacizumab, and in the wild-type, RAS wild-type patients, the anti-EGFR antibodies. These patients were randomized between placebo or regorafenib, or in the other study, placebo or TAS-102. And there was always a survival benefit. There was as well a progression-free survival benefit. And there was no there were no clear objective responses, with a few exceptions, with as well regorafenib as TAS-102. And then with regorafenib, we have seen 2 different studies. The CORRECT study, which was a pivotal study, which you and I had the privilege to guide and to lead. And this was a global study. And then there was an Asian study, the Concord study, in which patients were a bit less heavily pretreated. Patients were pretreated with the cytotoxics, but not with all the biological targeted agents. And also in the Concord study, there was a benefit. The benefit seems to be a bit higher. The hazard ratios were a bit more favorable in this Concord study. And then with TAS-102, we had the pivotal RECORE study, in also heavily pretreated patients. And before that, we had a Japanese study, a randomized phase 2 study, and then recently also the TERRA study. And also here we see similar results, TAS-102 with a benefit over placebo. And in the Japanese study, the initial Japanese study, the benefit seems to be a bit higher. That's probably patient selection in this situation.
I would agree. Now, Tony, you know, these drugs, as you mentioned, have different mechanisms of action. It's a kinase inhibitor, multi-targeted kinase inhibitor for regorafenib, with potential kind of collateral damage, you know, side effects, you know. And by the way, we actually don't even know how regorafenib really works in one patient. Could be a signature effect, etc. And TAS-102 is a conventional cytotoxic agent, you know, like a fluoropyrimidine. So what are the implications for side effects and side effect management here?
Yeah, so they're a little bit different. The toxicities with TAS-102 are traditional toxicities that you would expect with cytotoxic therapy, primarily neutropenia, but also other hematologic toxicities. There's also GI toxicities and cumulative fatigue. You know, in this line of therapy, the difficulty, of course, with assessing toxicities is most patients have little exposure to the drug. The few actually that benefit and continue through the drug, we understand a little bit more about the later toxicities. Regorafenib, on the other hand, has very immediate toxicities. In the first 2 to 3 weeks, you will see some of its signature toxicities, if I may say. Hand and foot syndrome can be quite severe in the first 2 to 3 weeks. 15–17% of the patients will have grade 3. Fatigue, again, something you see in this line of therapy across all agents. It's a function of the drug, but it's also a function of where patients are in the disease. And there are, of course, other toxicities that are particular to these TKIs, diarrhea, a little bit of hypertension. But overall, you know, the toxicities seem to relate to the mechanism of action. With regorafenib, unlike other TKIs, you tend to see those toxicities a little bit earlier. Regardless, with both agents, those toxicities tend to happen in the first 4+ weeks, at least the toxicities we need to pay attention to, like febrile neutropenia, for example, with TAS-102, or hand and foot syndrome with regorafenib. And for those patients, we tend to follow them very closely in the first 4 weeks to adjust for the toxicities.
Okay. Yeah, so when I look at these two different agents, the toxicity profiles from a patient perspective are quite different, you know, because patients normally do not feel asymptomatic neutropenia. And patient that I've had on TAS-102, except for the fatigue, you know, probably also an effect of this later line setting, they sometimes don't even know whether they're on the drug or not. So you could potentially really run a placebo-controlled trial. For regorafenib, things are different. And so, Eric, how do you communicate this to patients in terms of what they can experience? And are there some guidelines, you know, what you tell them how to prevent or communicate with you, and how often do you see patients in this setting?
Well, with regorafenib, this is very important. It's also important with TAS-102. With TAS-102, what we tell to the patients is mainly with neutropenia that they should call and if they don't feel very well, and watch their temperature, because although more than 30–40% of patients had a grade 3–4 neutropenia, there were only around 4% of patients with a febrile neutropenia and an infection. So, but they should know that, of course. With regorafenib, we inform the patients of the different adverse events that are potentially there. And especially this was more an issue in the beginning when we used higher doses. Today with the lower doses, that's a lesser issue. But we inform them that hand-foot skin reaction and or diarrhea may occur. And that what I usually do with my patients is I see them every 2 weeks in the beginning, but that after a couple of days, if they have some problems, they should call. But we see them systematically at day 14, all these patients, to figure out whether they are having some adverse events and to manage some of these adverse events. And on top of that, we inform them of some preventive measures, also to try to avoid hand-foot skin reactions.
I mean, you pointed out to hand-foot skin reaction. I think hand-foot skin reaction, fatigue, some voice changes, those are the ones that patients really feel, compared again to asymptomatic neutropenia for a lot of patients on TAS 1 or 2. So I do believe, and I completely agree, patient communication is important, and checking on them either by phone or by seeing them back, doing the liver enzyme monitoring, which is also important because we see some hepatotoxicity. So in this roundtable discussion, I think we explored real efforts to optimize later-line therapies using existing agents that we have available and from a regulatory perspective. Thank you for listening. Hope it was interesting for you and for your clinical practice.